Insulin insensitivity, metabolic syndrome, and type 2 diabetes are probably the best place for anyone who's new to nutrition to start because there's a lot of patients with this condition. There's 88 million people with insulin insensitivity and another 34 million that have gone into diabetes. It's a huge patient pool. And also, a lot of these patients don't know that they have the disease. The other reason it's good is you get good results and the treatment is very straightforward. You don't have a lot of situations where, well, should I do this or should I do that? It's just straightforward. This is the Dr. Seuss version of nutritional therapy. I'm Paul Varnas. I'm a chiropractor. By way of disclosure, I want to say that I do work with Zorix International and I will mention their products from time to time, but the research and things that I'm presenting to you are pretty solid. Medicine is doing such a bad job with chronic complaints that I think this is our time. Our healthcare costs are $3.7 trillion a year, and you and I both know that we can bring that cost down. I think one important thing that we need to do is to talk science. So I'm putting a lot of the science on wholehealthweb.com and on my site, drvarnas.com. Feel free, visit those sites, tell your colleagues about them. And like I said earlier, there's a lot of people with insulin insensitivity and diabetes, over 100 million people, 34 million diabetics, 88 million insulin insensitivity, and a lot of them don't know, okay? Insulin insensitivity, only about 11.6% know that they have it, and a lot of diabetics don't know that they have it. 7.2 million Americans have diabetes and don't realize it. So you can start doing A1Cs in your office and treating this and getting really nice results. Early symptoms of insulin resistance include fatigue, brain fog. They crave sweets or carbohydrates, become sleepy, or crave desserts after meal. And I should add, carrying around extra weight. If a person's overweight, there's a really, really good chance that they have insulin resistance. And in the lab, an A1C of 5.7 to 6.4 shows insulin resistance. If it's above 6.5 on two different occasions, then the person has diabetes. For metabolic syndrome, sometimes called syndrome X, this is from JAMA. Three or more of are present. Waist measurement greater than 40 in men or 35 in women. Triglycerides greater than 150. HDL lower than 40. And I would add to that high LDL or high total cholesterol. Their blood pressure is above 135 over 85. And let me point out too, about half the patients that you have that have high blood pressure have insulin insensitivity. So if they have trouble bringing down their blood pressure, you should start addressing insulin. And fasting glucose of 110. So any three of those things are present, the person has metabolic syndrome. I'm going to go over the drugs a little bit, but I don't want to spend a lot of time on this. If patient's taking a diabetes drug, make sure, and you're doing lifestyle change, make sure that they monitor their blood sugar because this stuff works. Also, if you want to see this material, it's in a patient report on drvarnas.com. Pretty much everything on this slideshow is in that booklet, and it's for you to give to your patients. I'll customize it for you. I'll make it look like it came from your office. You can go to drvarnas.com and download it. I won't even take your information. But right now, let's go over a couple of drugs. The main thing about biguanides is that they decrease vitamin B12 levels, and you want to make sure if you have a patient on that, you want to give them some B12. And you want to give them a high dose. Oral doses of B12 that are in the RDA range, like 400 micrograms, won't do a lot of good. You have to get up around 2, 3, 4 milligrams per day to replace that. One of the big signs of B12 deficiency is cognition issues. And so if you have someone who's, in fact, it could get so bad that it'll mimic Alzheimer's disease. So when you take your history, if they're taking biguanides, make sure that you give them B12. They're contraindicated in patients with heart failure, recent heart attack, or liver problems. And I bring this up because a lot of times the prescribing doctor will ignore little things like that. Alpha glucosidase inhibitors interfere with the absorption of starch and sugar in the gut. They're contraindicated folks with kidney disease, liver disease, and ketoacidosis. Also, any kind of GI issue. If they're having GI problems, inflammatory bowel disease, IBS, intestinal obstruction, these are not great drugs to take because they work in the intestine. They form a lot of gas. So patients taking this have flatulence, diarrhea, nausea, and abdominal pain. A lot of flatulence. You might want to schedule them where there's not a lot of other people around. Glucagon-like peptide-1 receptor agonists mimic hormones that help lower blood sugar after a meal. They delay gastric emptying and give you a feeling, a sense of satisfaction with the meal. They include Trulicity, Ozempic. And there's a danger of pancreatitis. There's possibly cause pancreatic cancer and thyroid cancer. The most common adverse effect is nausea or vomiting. Most of these drugs have some kind of GI issue with them. Meglitinides are taken right before a meal. Side effects include hypoglycemia, weight gain, GI upset again, and back pain. Sodium glucose transporter inhibitors work by preventing the kidneys to hold on to glucose. This includes Farxiga. You've seen the ad, little guy dancing. And the little guy's dancing because he doesn't realize that the drug that he's taking could be fatal. He could have acute kidney injury, urinary tract infection, and Fournier's gangrene. Fournier's gangrene is horrific. It's a flesh-eating bacteria in your crotch. I mean, literally, your crotch will fall off. Be aware if your patient's taking this. So if the patient has any tenderness, redness, swelling in the genitals, or if they run a temperature for a while, these symptoms can worsen quickly. They have to get to a doctor right away. And this is why you need to be aware of these drugs, because they don't tell you that much on the ads. And sulfonylureas cause your body to make more insulin. They've been around for a very long time. And you notice the less severe symptoms from the older drugs as compared to the new drugs. And you might ask, why are they making the new drugs? It's not so much an improvement as that the patent ends on the old drugs. So they like to come up with new stuff, and the new stuff, well, can be dangerous. That's where you see the pancreatitis. That's where you see the gangrene. And the reason I went through the drugs is you'll notice that all the drugs work by blocking glucose somewhere in the body, whether it's the gut or makes a hormonal change, or it does it in the kidney. But the best place to block glucose is the mouth. And they've studied and found that the diet and lifestyle does outperform the drugs. Here's one from the New England Journal of Medicine. This is about converting from prediabetes to diabetes. There's others that show you can bring down A1C. And I have to point out that the dietary approach in some of these studies is pretty lame. We're going to talk about more effective dietary moves later. This is more like, watch your food and exercise a little bit, very minor things compared to what we're going to be talking about. This is all in that report that I showed you. Here's another one with people with impaired glucose tolerance not converting to diabetes, much better in the lifestyle group. Here's one in JAMA where they're lowering A1C in diabetics. Here's another one in JAMA, partial remission of type 2 diabetes, diet and lifestyle. A ketogenic diet's been studied and found to be much more effective than the types of diets that were in those previous studies. We're talking about limiting carbohydrates to 50 grams a day to as little as 20 grams a day. And they lose weight, they get more glycemic control. It's very effective. The only thing I would caution you about is pushing ketones through the kidney is hard on the kidney. So in a diabetic, you want to make sure their kidney function is pretty good. And you might want to consider giving them keto sticks, which you buy in a drugstore. They can measure how much ketone is showing up. So if you pee on the stick, and if it's very, very dark, you want to maybe give them a little extra fruit or something. It's not a good idea to keep them in hard ketosis, at least to protect their kidney. Here's another study on the ketogenic diet. They've done a fair amount of studying. It is effective, but like I say, watch the kidneys. There's another study. This is all in that report that I told you about. And take a minute to talk about glycemic index and glycemic load. They're important concepts to grasp because they're used interchangeably and they're really telling you two different things. Glycemic index is telling you how fast the carbohydrate is being converted into sugar. It's a measure of what 50 grams of carbohydrate of a certain food will cause your blood sugar to rise. Glycemic load is a much more accurate way to determine which foods to eat and which foods to avoid. Glycemic load is the glycemic index times the number of grams of carbohydrate in a serving divided by 100. And I'll give you an example. Most fruit has a high glycemic index, but not so much of a glycemic load. There's 9 grams of carbohydrate in a half a pound of watermelon. Okay, so you'd have to eat 3 pounds of watermelon to get the glycemic load to equal the glycemic index. So glycemic load is a much more useful concept, much more useful to tell your patients to follow a diet paying attention to glycemic load. And I've got a little chart. This is in that booklet that you can download at drvarnes.com. It's got both the glycemic index, the number of carbs in a serving, and the glycemic load. And if you go through it, you'll notice that fruits have kind of a high glycemic index, but the glycemic load is not terrible. And you'll see that paying attention to glycemic load brings down A1C. Several studies show that, and the authors all say targeting glycemic load rather than fat grams or calories or anything like that is much more effective. So there's no one diabetes diet. You've got several choices here. If you have someone with pretty healthy kidneys and you want to try a ketogenic diet, it'll be very effective. Glycemic load and having the patient eat less than a glycemic load of 10 is also very effective. They can download lists from the internet. And this diet, this is downloadable at drvarnes.com. It's free, the PDF. Zorex will send you printed copies when you buy products from them. And I like this diet because it does a lot of things at once. It's nutrient rich, it's high in antioxidant, improves digestion, balances the microbiome, and is anti-inflammatory. And I usually sell it as do this for 30 days. You can do anything for 30 days. But it comes up every once in a while. I just talked to a practitioner that had this problem. Is the patient is intimidated by the diet. He's got to give up all these things he loves. Because quite frankly, the junk foods we eat are designed to be addictive. McDonald's is designed to be addictive. And so they don't want to give up their addictions. So a lot of times nutritional therapy turns into a negotiation, what the patient is willing to do, and you try to get them to do as much dietarily as they can. I was always fond of telling patients, you know, I love people that don't listen to me because I make more money. I had 3 kids to put through college, and I'll be selling you more supplements, and I'll be seeing more visits. And frankly, if you're managing these people, you hit it hard. We're going to go through like a protocol at the end. And the less compliant they are, the more supplements you're going to use. You know, you don't have to use everything that's in that protocol, but it gives you a toolbox to use. Like I say, nutrition is a negotiation. And take a minute to talk about glucagon and insulin and intermittent fasting. When you eat a meal for 3 hours thereafter, insulin is the dominant hormone. It is the hormone that stores calories for you so that you can use them for energy later on. After 3 hours, glucagon, which helps you mobilize those calories, becomes the dominant hormone. This is one reason why snacking is such a bad idea if people are trying to lose weight, because every time you eat something, you bump up, you start producing insulin, and you lose that opportunity to have the glucagon break down your calories for you. So that's why intermittent fasting, and it's been studied and it's very effective in people with insulin insensitivity. You give the person an 8-hour window to eat. There needs to be 16 hours between dinner and breakfast in the morning. So if you eat dinner at 5 p.m., you can't have breakfast till 9 in the morning. This speeds up the breaking down of fat. This helps get insulin insensitivity under control. It's very effective. Okay, it's also very hard to get people to do this too. But what you should insist on is that they not eat anything between dinner and bedtime and try to discourage snacking. Get your diabetic patients and your insulin insensitivity patients moving. It's well studied. This will improve their situation. Doesn't have to be a heavy workout. In fact, light workout is better. Exercise lightly, on a bike or go for a walk even. They should be able to hold a conversation while they're doing their exercise, but have them exercise about 30 minutes every day. It will help a lot, and it's well studied. A lot of different nutrients have been studied and shown to improve glycemic control. Here's for vitamin A, vitamins D and K. But the important ones are B vitamins. B vitamins are all over the Krebs cycle. Niacin and folate especially. Thiamine is also important. They help convert your sugar to energy via the Krebs cycle. In fact, a lot of people that are craving sugar need to have the Krebs cycle ramped up a little bit, and B vitamins will do that. Similarly, minerals will help with glycemic control. The most important one here is magnesium. Magnesium, again, runs the Krebs cycle. It's also widely studied to show that it helps with insulin resistance. And those earlier slides are more to get the idea of just about every vitamin company has a glucose handling product. There are multiple vitamins high in the nutrients that have been studied to bring blood sugar glycemic control. The one from Zorex is called CGF, which is complete glucose formula. There's some of the constituents in it, and it's a good product. And one thing in CGF that's different is it has glandulars in it. And glandulars were pretty big in the 40s and 50s. Upjohn manufactured adrenal glandular extracts right up until the late 1950s. There is research supporting them. It's older research, some of which the Germans did research where they found that if they radioactively labeled glandular tissue and a person ate it, the radioactivity would show up at the gland. If you eat pancreas extract, it goes to the pancreas. So the rationale was you're giving building material to repair these things. I need to emphasize that everything on this slide, we're talking about type 2 diabetes or insulin insensitivity, not type 1 diabetes where a person beta cells have died and they have to take insulin. The treatments are different for these people, except for two nutrients. One is magnesium, the other is lipoic acid, which we'll get into in a minute. Magnesium, if you have insulin resistance or if you're diabetic, you lose the ability to pick up magnesium, to absorb it from your diet. So you need extra magnesium just for that reason. And conversely, magnesium is necessary for glycemic control. So this is an important nutrient. If you give them nothing else, you should be giving them magnesium. And there's some of the research supporting the use of magnesium. It's listed in that report in drvarnas.com. It's a free download. The best magnesium to give someone with diabetes or insulin insensitivity is magnesium taurinate because it helps lower blood pressure and it improves lipid profiles. Also, both magnesium and taurine will help with tachycardia. So your high blood pressure patients, your patients with insulin insensitivity, give them magnesium taurinate. The other nutrient that's important for both type 1 and type 2 diabetes is lipoic acid. It's been studied and shown to improve cholesterol and triglyceride levels in patients with diabetes and insulin insensitivity. And I would go so far as to say 600 milligrams a day of lipoic acid. If I see high triglycerides, that's always part of the therapy. And here we have a study and a meta-analysis supporting that. Patients taking lipoic acid improved insulin sensitivity, had lower cholesterol, lower triglycerides, and lower LDL, or the bad, quote unquote, bad cholesterol. And they also experienced a reduction in inflammatory markers. So you want to bring down inflammation, lipoic acid is a good substance to do so. Powerful antioxidant. The main reason you give lipoic acid is to protect from neuropathy and to improve neuropathy and to mitigate cell damage of diabetes. So every diabetic, I think, should be on magnesium and magnesium taurate specifically and lipoic acid. And like I said, lots of studies. That this is in that report on drvarnas.com. Obviously, a lot of companies make lipoic acid. We're going to give Zorex a plug here because they do make all this possible for me to do. And it's 100 milligrams of lipoic acid plus mixed ascorbate, so it makes it a little bit more powerful of antioxidant than just straight up lipoic acid. Dosing lipoic acid, you want to give about 600 milligrams a day if you're dealing with triglycerides or trying to prevent neuropathy. Berberine has been well researched and shown to reduce blood sugar and A1C. Berberine, you might remember, is involved with the microbiome and helping that. And it may be a good choice for someone who's been on the drugs and is starting to have GI problems. You want to reverse those. Berberine might be a good choice to do both blood sugar control and microbiome. So people taking berberine, studies have shown it decreases A1C, fasting blood glucose, postprandial blood glucose, and triglycerides, another one for triglycerides. So if you see high triglycerides, a lot of times you'll see a patient that's got high triglycerides and they're on a statin. I never understood that. But you've got now have two tools. You got berberine and you've got lipoic acid to bring that under control. And berberine also may help with fatty liver disease, which we're going to talk about in a little bit. And we'll give Zorex a plug again. 500 milligrams of berberine. What's interesting about the Zorex product is the capsules are designed not to be destroyed by stomach acid because you want berberine to be working further down the line. I think that's a pretty smart design thing. And that's one of the things I like about Zorex. Their stuff is intelligently designed. Once again, lots of studies for berberine. You can download the report. You want these references. Lots of studies supporting berberine for blood sugar control. So if you got GI issues and insulin insensitivity, berberine might be a good choice. Americans consume a lot of funny fats. And one of the most important things you can do for any patient, including type 2 diabetes or insulin sensitivity patients, is to give them a good oil. In fact, if you give them an anti-inflammatory diet and a good oil, you'll be surprised at how well everybody does. In the last webinar on pain, we talked about giving the oil and pancreatic enzymes. The pancreatic enzymes I usually reserve for someone who's in a lot of pain. The anti-inflammatory diet and the oil will do the job. For chronic people, they reduce inflammation, they help with blood glucose control, they help with serum lipids, and they help the brain in cognition. So I'm going to talk about alpha-linolenic acid, which is an omega-3 fatty acid found in flax. And it's well studied. It helps with serum lipids. It benefits diabetes, glycemic control. It's anti-inflammatory, helps balance serum lipids, helps prevent heart disease, helps prevent plaquing of the arteries. Americans consume a lot of funny oils, like I said earlier, and what's happened is when they take a lot of omega-3, they tend to improve in the short term, and so a lot of people out there have the idea that omega-6 fatty acids are bad, but they're not. They also help with biomarkers for diabetes and blood lipids and so on. They're good oils, but you want to be taking good oils. If you buy canola oil at Kroger, you're not getting omega-3, omega-6 fatty acids, and that's part of the problem. A good omega-6 as a nutrient is a good thing to take. And when I say omega-3 fatty acids, first thing that pops into everybody's mind is fish oil. All the studies that support fish oil are going to talk about. But the problem is the oceans are full of dioxin, mercury, and plastic. And a good company will check for the dioxin and mercury. Plastic's a lot of lightweight chemicals. I don't know how you test for that. Dr. Ray Peat, who's either a biochemist or a biologist PhD, he's got a website, raypeat.com. A lot of well-researched information. His newsletter is excellent. He's got one on essential fatty acids. And he says the omega-3 research is flawed. And I know the argument, flax oil has to go through two chemical reactions to become eicosapentaenoic acid, fish oil. So fish oil is quote unquote much more active. Okay. But the reason the studies are so good is Americans eat 30-to-1 ratio of omega-6 to omega-3. And like I said, they're not good omega-6 fatty acids. So you give someone like that a drug-like blast of omega-3 fatty acids, you're going to get some short-term improvement. And Dr. Pete is hell on fish oil. Download his newsletter. It's anti-thyroid, immunosuppressive, lipid peroxidative, anti-mitochondrial, depression and glucose oxidation, and contributes to cancer, liver damage, and other things. As far as fish oil goes, I would say maybe if you do decide to give it for one bottle. Don't put someone on fish oil and leave them there. If especially your junk food junkies, I understand that that's not a bad concept, but long term, we're going to give Zorex a plug here. Sunflex Complex is their essential fatty acid formulation, and they don't even make a fish oil. Okay, the proportion of omega-6 to omega-3 fatty acids is 3-to-1. More omega-6, that's what your cell walls like, or cell, if you don't have a cell wall, you're not a plant. That's what your cell membranes like, okay? And consider it for the same things that you would use fish oil for: cardiac insufficiency, ADHD, arterial sclerosis, high cholesterol, hormonal dysfunction especially, pain and inflammation. This is a good product. And if you do nothing else for anybody with a chronic problem, you give them sunflax and you put them on an anti-inflammatory diet, you've got a competent nutritional practice right there. Insulin insensitivity leads to fatty liver. Fatty liver can lead to biliary stasis, and that can progress to gallstones and other problems with the liver, cirrhosis. One study linked insulin insensitivity and sugar consumption to gallstones and even cancer. So with fatty liver, you eventually get biliary stasis. Biliary stasis is when the bile becomes thick and sluggish. You're supposed to make, I forget, it's 1.5 quarts a day of bile. You start making less of it, and it starts getting thick. And it creates a lot of symptoms. The nausea or digestive distress, dry and itchy skin is a biggie. Clay-colored stools or fat or grease in the stool when it starts getting really bad. A lot of your reflux patients that they're taking Prilosec or whatever and they're still having problems, that could be biliary stasis. Constipation, you do everything that you should for constipation and you still can't get rid of it, consider biliary stasis. Okay, bitter metallic taste in the mouth. They'll become deficient in oil-soluble vitamins because bile emulsifies the oil-soluble nutrients, and so you can absorb them. If you're not making enough bile, that's why you get the dry, itchy skin. You don't have enough essential fatty acids. You're deficient in vitamins A, D, E, and K. Okay, it gets bad enough, you get pain under the rib cage, positive Murphy sign, when you push under the rib cage and it hurts and go yow. And a lot of times, this is recognized. You see it a lot of times in pregnant women that get itchy skin. It's biliary stasis. Okay, and now a word from our sponsor. Zorex International makes GB Complete, which thins bile and it helps increase bile production, helps prevent gallstones. A lot of companies make a product that does this. Most of them are made with beets, like your beta food, but they're high in oxalates, and that poses a problem for some people. And if you go to drvarnes.com, you can download the product sheet for GB Complete and see the research behind the constituents in there. It's a very good product. Obviously, there are others that do the same thing, but we'll give Zorex a plug because they're helping me do this. Well, here's a protocol for insulin insensitivity. And before I get into it, let me qualify this. If you give them everything and have them do everything on here, they're going to do very well. But like I pointed out earlier, nutritional therapy is always a negotiation. You're better off getting the patient to do some things. Like if a patient's very good with the diet and is short on money, you might consider, okay, do the diet, take some CGF and some sunflax. and some magnesium. Okay, out of those three, I would go the magnesium first, the sunflax second, and the CGF third. If they're not good with the diet, you really want to hit it heavy with the supplements. But anything you do will help. Nutritional therapy is cumulative. Um, Vince Lombardi said, "I never lost a game. I just ran out of time." With nutritional therapy, you're never wrong. You just didn't hit it hard enough, and you can explain that to your patient. And like I said, I tell patients that you don't have to do everything I say, but I'm going to make more money from you eventually. But see what you can get them to do. And as a priority, I would give them the oil and the magnesium. Magnesium is to be taken to bowel tolerance. Take magnesium. Magnesium binds to the fats in the meals. So you want to take it the very last thing at night, and then start with one in the evening, then take two, then take three. Eventually, the stools will get soft because it acts kind of like a laxative. When the stools get soft, say it takes 4 to get the stools soft, then their dose is 3 before bedtime every evening. And if you get them to, even just do a glycemic load diet, or you can sell them on 30 days to the roadmap to health. Give them that and some magnesium. They're going to do better. The more you do, the better they're going to do. So with diabetes, you want to make your lifestyle choices, daily light exercise, intermittent fasting. If they can follow the diet, the daily light exercise, and the intermittent fasting, they'll eventually come out of it. And then as many supplements as they can afford. I probably should have listed these in order. I would start, if they're actually diabetic, I would start with magnesium taurate and the LPA plus, the lipoic acid, 600 milligrams a day. CGF maybe next. But get them to take what you can. Once again, anything can help. This isn't drug therapy. We're basically helping the infrastructure, if you've seen any of the other webinars. I want to emphasize really quickly that even though the two protocols that you just saw have a lot of supplements in them, you can emphasize to your patient that's not forever. Once you get the blood sugar under control, you can back off of all the supplementation and just control it with diet and exercise. This is therapy. The other thing I want to tell you is that the material in this video automatically gives you a weight loss program. And we have materials for you to educate your patients. We got Diets Make You Fat, and we got a poster for your office so you can develop this into a weight loss program. The report will explain to the patient how this works. Insulin insensitivity is how you get weight under control. And the other thing that you need is the microbiome, which is why we're recommending the roadmap to health. If you give them the roadmap to health diet and the supplementation for insulin insensitivity, you have a diet program. And it's a slow, steady thing because lifestyle works better than dieting. And thank you. I know your time is valuable. I appreciate you sitting through this.